So today we are going to talk about case-based management of aortic stenosis. And I'll try to keep it as simple as possible, okay? They'll do not have much data on the slides. It'll be just pure guideline-based. I have no disclosures, unfortunately. So aortic valve stenosis, it's a mechanical problem, okay? So if you just think about a garden hose pipe, okay? If you pinch the garden hose pipe, the pressure with which the water comes out is faster. The same mechanism works. Valves get thickened, they degenerate, they calcify, they narrow down. And what happens is you have a high pressure gradient across the valve. Just if you look at the cartoon on the lower bottom corner, that tells you that thing. Your LV pressure is like 200, your aortic pressure is 110. You have a 90 millimeter gradient across the valve. And as this gradient increases, you will have problems. Your LV will see the pressure, it will thicken up, it will dilate, your function will go down. Eventually, your left atrium will see the elevated pressure, and that will give you the shortness of breath. So this increased pressure gradient and the magnitude of the pressure gradient leads to the symptoms. The symptoms of the aortic stenosis are also very simple. There's rarely a zebra when it comes to the presentation of aortic stenosis. Chest pain being one of the common features. It's because of reduced coronary flow and reduced diastolic gradient across the endocardium. Syncope or dizziness because your cerebral flow is reduced because your cardiac output is low. Dyspnea and exertion, the most common presenting feature of aortic stenosis. Because of elevated end diastolic pressure, your LA pressures are high, which basically this is what your lungs see, and you get short of breath. Fatigue and impaired exercise tolerance is also one of the more common presenting feature. And this last thing, this is the thing that everybody worries about. When you have a patient of aortic stenosis in your office, the first thing they will ask you or you worry about is, how long will I live if I don't get it treated? Sudden cardiac death. So this is the common nomenclature that we use in all textbooks or guidelines. Severe stenosis is defined as valve area of less than 1 centimeter square, mean gradient of more than 40, and an aortic valve velocity of more than 4 meters per second. This is accepted all across the board, as this is the classic indication for treatment of severe aortic stenosis. Everybody must remember this slide. This is a famous slide from Dr. Braunwald, published from back in 1960s, which talks about the natural history of aortic stenosis, or what happens to these patients. So if you look at this particular point where you have onset of severe symptoms, so starting at this point down, your survival is 50% at 5 years. 50%. That's like one of the two patients will die if nothing is done. However, if you look at this square, if you add LV dysfunction on top of it, your survival is reduced to less than 2 years. So if you don't treat a mechanical problem when it's symptomatic, you'll end up in trouble. So if you ask me what's the problem for a mechanical stenosis, the answer has to be mechanical as well. Okay, let's talk about the therapy that are available and how we should navigate through certain patient scenarios. Case number 1, 80-year-old man, active, has dyspnea and minimal exertion, NYHA class 3 symptoms, heart rate 64, blood pressure of 110/90. He has absent S2 with a late peaking systolic murmur. EF is preserved at 55, mean gradient of 60, and a valve area of 0.6. Normal coronaries, no major risk factors. What next? Would you proceed directly to AVR? Do you do medical therapy, routine surveillance, follow up the patient in 3 months with a repeat echo? Or do you think that given the age and everything, the risk is very prohibitive and you should opt for hospice? Mara Japo, that's the word used here, this part of town. Thoughts? You can shout out. How many people think that you should proceed with AVR, aortic valve replacement? Everybody. How many think that there should be medical therapy? You should treat it medically. Anybody? Good. Mechanical problem only has mechanical solutions. Okay, so AVR is the right answer here. So this is the guideline chart from the ACC guidelines that was published in 2014. And so we determined that you have abnormal aortic valve with reduced systolic opening. You have severe AS that was determined by the gradients and the velocity, and the patient symptomatic. So this is a direct class 1 indication for aortic valve replacement. There is no mucking around anywhere else. This was a straightforward case of severe AS. So now coming to the point that what type of AVR, you have two options. Either you can do it surgically or you can do it via transcatheter. It's a hard team approach. It all depends on the surgical risk of the patient. Earlier in the day, Dr. Kapadia mentioned surgery for low surgery risk patients, or TAVR for low TAVR risk patients. That depends on the heart team. So this patient doesn't have any significant surgical risk, and surgical AVR would be the first thing that should be offered to the patient, and if the patient refuses, then should go for TAVR. Case 2. 80-year-old man, active, but completely asymptomatic. You know the patient well, and the history is extremely reliable. Vitals are normal. Examination fits severe aortic stenosis. EF is 40%. No other risk factors. Gradients are severe, and normal coronaries on angiogram. What next? These are the 4 options. Patient's asymptomatic. Anybody opting for medical treatment? No one? Okay. Anybody opting for AVR? Okay. Majority of the crowd. So that's right. AVR is the therapy for this patient. And the reason being is the patient has severe AS, but the patient is asymptomatic. So in that case scenario, when you have reduced LV function less than 50%, meaning that even though you're not feeling the symptoms, but your heart is feeling it, so it needs to be replaced. The other indication in this particular group includes if you have any other cardiac surgery, like asymptomatic AS, but the patient has severe MR or something of that sort, and then you can do that. One of the other thing that you should look forward as well is a Vmax of more than 5 meters per second. These people are at a very high risk for sudden cardiac death. Their survival is extremely low. So this particular group of population, irrespective of whatever their EF is, they undergo AVR directly. The other thing is abnormal ETT, meaning reduced blood pressure or heart rate response during exercise, and the patient gets symptomatic on the treadmill, then you can send the patient for AVR. Okay, let's do some more cases. Okay, 76-year-old woman, dyspnea and exertion chest pain. EF is 25 with global hypokinesis. Gradient is only 28. It's not severe, it's not more than 40. Your cardiac output is 3.1, and your stroke volume index is 32 mils per meter square. What next? Would you directly, patient symptomatic. So now the main concern is whether the valve area is really small, or the valve is not opening because you do not have much forward output. And the question is, what do you do next? Do you directly proceed with surgery, or you take any other approach? So the option here would be to do a dobutamine stress echo or an aortic valve calcium score to figure out how bad the aortic valve stenosis is. So if you have an increase in the stroke volume, and with the increase in the stroke volume, if you see that your gradients get worse, and your aortic valve area is also less than 1, then that is true severe AS, and you proceed with AVR. And if your stroke volume increases, but your gradients do not get better, then you then that is pseudo-severe AS. The reason your valve area was small was because the ventricle was not pumping that much blood forward to open the valve. So that is this group of population. When you have low EF with symptomatic moderate AS on clinical exam. Okay, let's do one more case before the timer goes off. 75-year-old man, dyspnea on exertion, chest pain, moderate AS with severe multi-vessel disease on angiogram, EF of 65%. This is a common question asked by the surgeons. What to do? Would you just do cabbage and leave the aortic stenosis alone, or you treat the aortic stenosis because you're already there? What do you do? A. Okay. So that's a class 2A indication for cabbage and AVR. So like patient scenario like this, PCI would not be a viable option because then you do not treat moderate AS patients with TAVR. We have time for one more case? 30 seconds, okay. Advanced CKD, lots of risk factors, EF of 65%. What would you do? Medical therapy, SAVR, TAVR, or do you think it's futile to offer any therapy to a patient like this? Moderate severe COPD, advanced CKD, prior stroke, but EF's normal. TAVR. TAVR would be an option if it can be done safely. Okay, thank you.